Hello and welcome. I am Cora Fox, and I am Associate Professor of English and the coordinator of the Health Humanities Initiative at the Institute for Humanities Research. And I have been your host for this 4-part series of webinars on the histories and cultures of epidemics. Today is our final webinar, but if you missed any of them in the series, I wanted to let you know that they are available as recordings on the IHR YouTube channel. You just have to search for IHR space ASU and the channel should come up. Today we are welcoming Rana Hogarth, whose research focuses on how medical professionals constructed racial difference as a medically significant category in the 18th and 19th centuries, and how approaches to the yellow fever epidemic reflected and influenced these cultural negotiations. Our hope for the series overall is that highlighting this history and providing a platform for research such as Hogarth's will make it more central to understanding and providing care in the current pandemic crisis, which has revealed the vital ways in which health depends on culture and history as much as it does on technology and science. I will take a minute here to thank the many behind-the-scenes staff members who have made this whole series work, especially Liz Grumbach, Lauren Whitby, Barbara Dente, and Selena Osuna. And I'd also like to thank the Institute for Humanities Research and Ron Broglio for funding these events. I think they've been wonderful and important, and I really appreciate having this space for this kind of work at ASU. I would like to thank now and welcome Annika Mann, who is serving as my co-host for this event. Annika is an associate professor in the School of Humanities, Arts, and Cultural Studies. She works on 18th century British and Romantic literature and culture, and particularly the history of medicine and print culture. In 2018, she published 2 books, one a monograph titled Reading Contagion, The Hazards of Reading in the Age of Print, and the other, as she was co-editor of a volume called Transforming Contagion, Risky Contacts Among Bodies, Disciplines, and Nations. I will turn this over to Annika to introduce our guest in just a moment, but first I wanted to give an overview of what to expect for the webinar. First, Professor Hogarth will offer a short presentation on her research, followed by a Q&A discussion with Professor Mann. And then in the last 10 to 15 minutes, we will open it up for questions or comments from those who are present. To simplify things, we have disabled the chat feature in Zoom, so please instead use the Q&A feature at the bottom of the screen to submit any questions that arise during any portion of the event. And I will do my best to curate those questions and address them at the end to Professor Hogarth. So, okay, I think that's all of the technical out of the way. Thank you for joining us, and I will turn it over now to Professor Mann.
Hi there, I'm Annika Mann, an Associate Professor of English, as Dr. Cora Fox just introduced, and I'm thrilled for the chance to introduce our speaker today, Dr. Rana Hogarth, Associate Professor of History at the University of Illinois. Dr. Hogarth holds a Ph.D. in history with a concentration in the history of science and the history of medicine from Yale University, and an M.H.S. in health policy from the Johns Hopkins Bloomberg School of Public Health. Dr. Hogarth is author of numerous peer-reviewed journal articles, including articles in the Social History of Medicine and the American Journal of Public Health, as well as this wonderful book, Medicalizing Blackness, Making Racial Difference in the Atlantic World, 1780 to 1840, which focuses on medical and scientific constructions of race during the era of slavery and beyond. In her book, Dr. Hogarth explains how white physicians, drawing upon centuries of objectification of Black bodies, medicalized Blackness during this period as a medically significant marker of difference in slave societies in the American Atlantic. As Dr. Hogarth shows, this medical marker allowed for the construction and stabilization of racial difference, even as it advanced the careers and professional standing of white physicians. Importantly, while in her book, Dr. Hogarth punctures many of our standing myths about the construction of race during this period, her book also challenges much of the scholarship in 18th century studies by recentering the Caribbean as an extremely influential site for the production of medical and scientific knowledge. That is, Dr. Hogarth's work illustrates how medical ideas first moved from the Anglophone Caribbean, particularly islands like Jamaica, to the antebellum South, particularly places like South Carolina. In making the movement of these ideas visible, Dr. Hogarth centers the Caribbean as what she terms a formative space rather than a peripheral one. We're so excited to hear more from Dr. Hogarth today in her talk entitled Medicalizing Blackness, Lessons from the 18th Century American Atlantic.
Wow, thank you very much for this very generous introduction. And also thank you very much for inviting me to participate in these webinars. What I'd like to do now is I'm going to share my screen and share some slides that I have for you today. And I'm basically going to provide a little bit of an overview of one episode that I discuss in the book, particularly the 1793 yellow fever epidemic, as I think it's very much timely and on point with what we're dealing with today. So just by way of a very brief sort of reiteration of what the book is about. So medicalizing blackness is sort of, you get to make up a term, I guess. So medicalizing was it for me. And that was basically a way of trying to understand how physicians were viewing Black people's bodies and saying, aha, there's something about this feature that has clinical significance. It became a marker of difference, and they used this to sort of make the idea that racial differences were real, right? It's a way to say, aha, we can have proof of racial differences when comparing bodies. And I want it to be kind of very clear that in doing so, creating this idea that Blackness is something like a feature that has this clinical value, that helps to reiterate the idea of racial differences being real. But also, and this is sort of one of the key points that I do make in the book, and that is to say that there was a lot of ideas that these physicians were trying to defend slavery, right? That they came up with such claims about Black people's bodies as a way of defending slavery. And it turns out that that's not actually always the case at all. One could be very much opposed to slavery, but be very much in favor of the idea that Black people were racially distinct and peculiar. And I will talk a little bit more about this today, as I will be focusing on Benjamin Rush. So for those of you who are really into early America, who are into sort of the history of medicine, he should probably be maybe a familiar name. He was very much opposed to slavery, but was very much a significant figure involved in making this idea of racial difference real in this time in the early Republic. So what I want to do is talk a little bit about yellow fever, because it's a great example of how Blackness becomes medicalized. And I want to take you with me into the 18th century, if you will. And I want to sort of kind of lead you through a story. Essentially, in 1793, there's sort of the well-known yellow fever epidemic that struck Philadelphia, which was the nation's temporary capital. Now, 1793 is fairly late. I should say early on, by the mid-18th century, physicians had been commenting on certain diseases like yellow fever and noting who were the people who seemed to get this disease. And it turns out there was sort of a trend. If one reads through many treatises on yellow fever, which I have done, you will find that there are sort of these references to, oh, well, but this race seems to not get it. And this race happens to be people of African descent. So what we see is that physicians observed that yellow fever appears to attack people based on their race. And the claim there was, okay, well, here are people that are seem to be resistant, African Americans. There was also the idea that white people and those who were unacclimatized to the Americas were very vulnerable to the disease. Now, the problem, of course, with this is that you might say, well, it's just a comparison, it's an observation. What really happens is that erasures of Black suffering from this disease are sort of scattered throughout the record, right? You can kind of look and see absences of, wait, where were cases of Black people, having their grievings, their sort of suffering and their grievances being aired during these yellow fever epidemics? It's not there. And this is a problem. So for me, in one of my slides I'm going to show you today, there's actually a great case where African Americans kind of respond to the idea of the erasure of their suffering. It's a fascinating find, and I think, again, we can maybe draw parallels between what's happening now during this pandemic and what happened in 1793. The other thing I have to say, though I am not a virologist, I can say that immunity to yellow fever, this idea that Black people are immune, that's not true. Immunity is acquired. It's not racial. The issue is that for many Africans, captive Africans who sort of brought over to the Americas forcibly, many may have had a bout of yellow fever and survived it. It turns out yellow fever is milder in children. If you survive yellow fever, then you're immune, but that's acquired, not racial. So the issue here is that many physicians who maybe are commenting on seeing enslaved Africans who don't seem to suffer, in some cases, we think that that might mean that they were immune, but acquired immune. So I'm going to just move on and sort of get to some of the key figures in this story that I want to tell you about 1793. Philadelphia, as I mentioned before, is a significant city. It's the temporary capital. 1793, there's sort of the fear of this might be a yellow fever like outbreak, a massive outbreak. Yellow fever visits the American Atlantic seaboard quite a bit. It's very common in the South. It's not necessarily a stranger to places like Philadelphia, but when it shows up, people panic. If you can flee the city, you flee. If you cannot, then you try and hunker down and hope that you do not get this. Now, Benjamin Rush, being a celebrated, well-known physician, a patriot, an anti-slavery sort of a staunch advocate sort of against slavery, he's sort of seen as a leader, a elite person, one that you can turn to in a time of crisis. And Benjamin Rush, having read many treatises about yellow fever, decides or sort of draws his conclusion that, it's true, people of African descent do not get yellow fever. And as I said, his ties with sort of anti-slavery work means that he had befriended members of the Free African Society in Philadelphia, led by Richard Allen and Absalom Jones. So there's the two figures here, Benjamin Rush and Richard Allen. And the issue is he actually says, okay, well, what can I do to help during this time? He's called upon to help. So he writes to Richard Allen asking for help, basically asking people of African descent, the free African American community in Philadelphia, to stay behind and help during the yellow fever epidemic. And one of the joys of being a historian, I love being a historian. I love going to archives. I love digging through people's letters. I really enjoy looking through this sort of paper trail to understand, how people made sense of these kinds of crises. And here is sort of the excerpt from the letter that Benjamin Rush sends to Richard Allen, which basically says, quote, "It has pleased God to visit this city with a malignant and contagious fever, which infects white people of all ranks, but passes by persons of your color." So this is him essentially writing to Richard Allen saying, look, we know, based on the evidence we have, you and your kind are not going to get this fever. Will you stay behind and help? Will you serve as nurses? Will you serve as sort of grave diggers? Will you come and sort of keep Philadelphia going when so many people have fled during this time of chaos? And the Free African Society, Richard Allen and Absalom Jones, they agree, right? They see in Rush an ally because as I said before, he is very much opposed to slavery. The problem, of course, is that people of African descent are not naturally immune to yellow fever. And Benjamin Rush actually does admit his error. So as you can see on this slide, he's noted to have said, quote, "I was led to believe that the Negroes in our city would escape it. In consequence of this belief, I published the extract from Dr. Lining's History of Yellow Fever, as it had 4 times appeared in Charleston, South Carolina." So what this means is that Rush read several treatises, one of which was by Dr. John Lining, who had lots of experience in observing yellow fever, and he sort of took what Lining said about Black people being naturally immune at face value. It turns out that he is wrong because, and this is where I say African Americans sort of, this is a moment where they kind of push back against them being erased. Richard Allen and Absalom Jones actually published an account, their account of the yellow fever epidemic. And they actually challenge the idea that they would naturally be immune. And it's one of my favorite passages ever in sort of this printed, this pamphlet, where it says, and I'll just read it, it is even to this day a generally received opinion in the city that our color was not so liable to the sickness as the whites. We hope our friends will pardon us for setting this matter in its true state. The public were informed that in the West Indies and other places where this terrible malady had been, it was observed that the Blacks were not affected with it. Happy would it have been for you, and much more so for us, if this observation had been verified by our experience. So this is basically them having stayed behind, doing their best to help out, and then realizing that that's actually not the case. In fact, Richard Allen contracts yellow fever and almost dies of it. He recovers, he survives, but this is sort of a case of very wrong information. And as I said, this is actually published. It's a narrative of the proceedings of the Black people during the late awful calamity in Philadelphia. So this is sort of a snapshot of African Americans pushing back against narratives that make sort of these broad generalizations about their health, what their bodies can and cannot withstand. And as I said, Benjamin Rush did admit his mistake in his sort of next treatise that he publishes. He says, quote, "They took the disease in common with the white people and many of them died with it. I observed the greatest number of them to sicken after the mornings and evenings became cool." Now, okay, he does admit he's wrong, but I do want to draw your attention to the distinctions that he makes in terms of when people of African descent get this disease. When he talks about the cool temperature, that's not just him noticing, something about the weather. There was an understanding at this time that environment and race and health were very much intertwined. And there was an idea that people of African descent were naturally preferred warmer and hotter temperatures, therefore shifting them into cooler temperatures would somehow render them liable to get all sorts of illnesses. So that's sort of what this is a gesture towards. The other thing I wanted to bear in mind is that Benjamin Rush then says that, quote, "The disease was lighter in them than in the white people. I met with no case of hemorrhage in a Black patient." Now, this is key because yellow fever is a hemorrhagic fever. It is deadly. It still is. The issue is that if you get to that stage, it doesn't look very good in terms of recovery. And so what he's basically saying is, okay, sure, people of African descent can get this disease, but they don't get it as bad. And I've never seen any of them have the sort of awful, awful worst outcome. That is not a non-trivial piece of information, because this goes to the idea of maybe Benjamin Rush is opposed to slavery, but he's also not opposed to the idea that Black and white people are different, that they experience and suffer differently. And this is something, again, that I wanted to draw your attention to, because, in doing this kind of research and in kind of researching a figure like Benjamin Rush, who is very much revered, people very much like Benjamin Rush, and he's an interesting figure. People will say, "Oh, well, I don't think he's a villain. He's not a bad guy." And I always say it's not really about villains. It's about sort of what that individual thought and did at the time. And at the time, and what he believed was that Black and white people were not sort of equal with respect to suffering. And I want to draw your attention to a quotation. This is something that I stumbled upon in the archives, but it's also something that's printed in one of his treatises. So Benjamin Rush, in sort of lecturing to medical students, as one did, he notes, quote, "A fact from Dr. Mosley of the indifference to which Negroes submit to operations and surgery in the West Indies. Even in this country, the Negroes have been observed to handle fire without an emotion and not suffering from it like white people." This is a reference to pain. This is essentially Benjamin Rush saying, well, based on what another physician has said, it seems to me that people of African descent tend to deal with pain better. Now, you might start to think, wait a minute, I feel like I've heard something about that, and you're right. There was the 2016 study on racial bias and pain assessment, which I will certainly address, but I wanted to sort of let you know that this is an idea that's pretty old. It's been around for a while. And as I said, I love being a historian. I love digging through people's lecture notes as well as their letters. And here's sort of where he makes that reference. So it's sort of in his notes talking about what Dr. Mosley says. There it is, but it's also, again, he publishes this in a treatise where he actually makes the claim that Black skin is Black because it's a kind of leprosy, which is something that I'm happy to discuss in Q&A, but that does indeed exist. And I want to kind of maybe expound on this a little bit more, just in the sense of Rush, as I said, signer of the Declaration of Independence, an abolitionist, respected physician. He was very much interested in ideas of race and racial difference, and he sort of participated in what I think of as this long enduring research question of why is Black skin Black, or why are Black people different or other or peculiar? That's sort of like where he started in terms of his, the questions that he would pose as a physician. And so I think it's important to think about what that means, having the standpoint of asking what is it about Black people, which puts the burden on Black people as being other, peculiar, and different, right? And so, as I mentioned before, in asking the question, why is Black skin Black, and making the claim that Black people are so supposedly better at withstanding pain, you can actually dig into this and find the published treatise that he wrote about, and I'm just going to quote it, quote, observations intended to favor a supposition that the Black color, as it is called, of the Negroes is the leprosy, which he is essentially saying that their insensitivity to pain, sort of observations he's made about Black people's bodies, leads him to believe that Black skin is a kind of leprosy that could possibly be cured. It's essentially him pathologizing Blackness and Black skin. So this is, again, when people say, well, how do you know what Rush really thought about Black people? He has left a paper trail. He's made it pretty clear in terms of his life as a physician and what sort of questions he chose to interrogate. As I said before, I promised you I'd try and tie this into the present moment. We can think about the pandemic in terms of who are the people that are essential workers who have to stay behind, who are forced to go out and work, who are now more vulnerable, and think about in terms of the Free African Society and African Americans in Philadelphia. We can also think about our present moment and say, think about perceptions of racial difference. So that Hopkins study that I mentioned to you was actually from 2016, so not that long ago. And the study's investigators found that white lay people and medical students and residents held false beliefs about biological differences between Blacks and whites. The study also revealed that, quote, racial bias in pain perception is associated with racial bias in pain treatment recommendations. So this is non-trivial, again. I wanted to sort of draw your attention to one of the findings of this study, this very troubling finding, was the belief that Black people have thicker skin than do white people, or that Black people's blood coagulates more quickly than white people's blood. So think about this idea of pain assessment, the idea of Black people having thicker skins, and then think back to what I had mentioned before about Benjamin Rush sort of writing in his lecture notes that Black people tend to bear pain better. So we're looking at sort of the late 18th century, and we're going all the way up to 2016. This is an awfully long time to have these sort of wrong-headed beliefs circulating. And it's sort of, it can just be lore that's passed down or something that people have heard or just something that people shrug and say, I don't know, I guess that's the difference. But it's clearly damaging. So what I want to leave you with today, I'm just going to kind of wrap up here, is to say that when we think about these sort of ideas about difference, that we can say, oh, these are wrong-headed ideas, these are terrible. This has to be the work of just a few aberrant racist people. I kind of want us to pause that for a little bit and basically say that it's not really about focusing too much on slavery or people who are clearly these aberrant racist folks, and actually to say that I think this actually might actually be built into the way that we acquire medical knowledge or how we sort of seek answers. So what I'm trying to say is that if we focus too much on slavery, it's easy for us to say, okay, well, those people were on the wrong side of history and they're bad, and we move on. I think that this is not about aberrations. I think this is actually representative of an approach to how we acquire medical knowledge. And this idea, as I said before, about asking the question about what is it about Blackness that makes it so? That's, I think, where the problem lies. And when we think about disparities, this also comes into play, right? When people say, oh, Black people are more likely to have or higher rates of X, that's fine in terms of understanding and acknowledging the disparity. But I also hope that people will say, okay, it's a function of how Black people's bodies are being regarded and how they're being treated in specific settings. And we should shift our efforts away from trying to understand, oh, is there a difference? What's the difference? To maybe saying, how is it that that person's body is being treated as it has to navigate an often hostile environment in a hostile space? So that's sort of where I hope to end us here, and maybe we can talk about that more in Q&A, but just sort of to think about ways in which it's about how racism, it's about how perceptions of difference can harm that body, rather than saying, the difference is within the body, putting the burden, right, on that person's body. So I will sort of leave it there and say thank you very much for your attention.
Thank you so much. That was wonderful. I have so many questions, but I thought I'd start with actually the sort of semi-happy thing from your talk, which is your joy of being a historian, and ask if there are areas of humanities research and maybe historiographical research in particular that you see as emergent or essential in this moment shaped by the pandemic.
Yeah, no, so yes, it's true. I love history. I'm a huge nerd. And so I think for me, during this pandemic, I'm actually seeing a lot of interest in what historians have to say about diseases of the past. And I think that in terms of, we can say, oh, we're learning from the past, but more than that, to actually restructure our approach to asking questions, if you know what I mean, like sort of thinking about what historians ask, thinking about what other people in other disciplines ask in terms of like, okay, what is it about this group of people, to shifting it, as I say, to say, okay, what is it about the nature of our society and the world that we exist in that can create some of the problems that we see? And I think that in this moment, like shaped by the pandemic, I've actually been thinking a lot about narratives and experiences and perspectives, right? So, we can all say, oh, this pandemic, it's affecting us all, but it's affecting us all really differently. And I am really interested to see sort of what kind of reflections and writings will come out of this, sort of the narrative of this pandemic and the different narratives that I think are going to emerge. For me, I mean, I think in terms of areas in the humanities, I think about literature actually, and I think about like, slight tangent, but I like always assign like the Journal of the Plague Year when I teach the history of Western medicine, right? It's great. It's fantastic actually. And I think it's a fun, the students think it's fun, but I think it's also an important way to understand like the living in that moment, right? What does it mean? And the different perspectives, and then the missing perspectives, right? So for me, I think that in this moment, I hope that, when I read like sort of long form pieces about, issues of food insecurity, issues of being forced to work as an essential worker, even the cases of like privileged folks who are at home, I'm seeing like these different snapshots of the pandemic, and I'm seeing sort of different perspectives woven together that I think completes this whole sort of story of what it is. And I think the story is going to keep changing and it's going to be ongoing. But for me, that's sort of where I see, I guess, the humanities informing this moment and sort of why I think the humanities matter so much. And again, so many historians are being called on right now to offer their insights, which I think is great.
Yes, I love Journal of the Plague Year. I tend to think it should be taught in every class, but that's maybe not.
It's so good.
But this sort of leads into another question, which is, at the Institute for Humanities Research, we're particularly interested in forging these kinds of collaborations across and outside various disciplines, both in the humanities and in the humanistic social sciences. And the pandemic, as you say, has revealed how particularly important this kind of interdisciplinary work is. And so we're wondering, from the perspective of your discipline and area of research, if you could comment on what particular kinds of collaborations you think will be essential. You sort of mentioned literature, but I'm wondering if there are others as well.
So I guess I can speak from personal experience. I think I've been doing a lot of work talking to medical students and physicians in training, and I think that having folks that do work in history or work in literature, sort of continuing to have dialogue with healthcare practitioners, so it can be nurses, whoever, is something I think is important going forward, right? I know that we'll say, okay, your training in this discipline is like, to look after, if you're a nurse or a physician, and these are things you're supposed to do for your job. But I think that taking a moment to reflect on sort of the relationship that between a doctor and a patient, whether that be historical or sort of how that goes from, different perspectives, from the perspective of the patient, like reading patient narratives and understanding what that means, I think is really essential, especially sort of now, because I was actually thinking about, people who might be afraid to go and get tested for COVID for a variety of reasons. One of them it had not occurred to me until somebody brought it up, but we have like these apps that are supposed to help you. What if you're a person that doesn't want to be tracked on an app, right? And you can immediately be dismissed as being non-compliant or be demonized as not, working together. And it's sort of like, you maybe want to think about this in terms of, why people make the decisions that they do and being aware of that, acutely aware of that. And I think physicians and nurses and even public health folks need to bear this in mind. So yeah, I think in terms of collaborations, I would hope that this is a moment where, whether it be medical students or community health organizations, clinics, whatever, are looking to maybe even read books, read something outside of what they're used to and say, okay, would this work for us? Should we be asking a different question? Or when we talk to patients or when people come in, maybe we should change the way we do things. And to me, that's a small step. And it would, it would be great if, I wouldn't say read a whole academic book, but certainly you could like think about illness narratives and just sort of be open, right, to considering another discipline and helping you make your day-to-day decisions.
Thank you. Well, and this raises, the series itself is an attempt to help make humanities work on the cultures of health more visible, so it can be used as you suggest. And we're wondering if you have suggestions about how academics could continue to do this, how we make visible this work in health so that it can have the kind of impact you describe.
Yeah, so actually, I was thinking about this. So particularly as a lot of what I talked about today has to do with Philadelphia. So it turns out that at the Library Company of Philadelphia, there is an amazing exhibition on. It's called Deja Vu. And it is, it's actually, I think, so a good friend of mine, a colleague, Deirdre Cooper Owens is the director for the program in African American history. And what she did is basically had students, underrepresented students, put together, right, an easily accessible, it's online, an exhibition that basically explored the experiences of African Americans during like cases of pandemic and illness, right? And the idea there is to say that's having students get in there and get their hands dirty in the archives, right? But it's not just presenting it like, oh, look, I've written a paper. It's a public-facing exhibition. The idea is to disseminate this. So you can, from the comfort of your home, click through, and perhaps it's even, yes, it would be great to go to Philadelphia and do that, but we can't do that. But we can still learn from this. And so I would say public-facing programs, right? Whether it be through, assignments for students now getting really creative and saying, okay, have students do their own like video journals if they want of their neighborhood or of how people are responding, to give a snapshot and like posting that to share with other students to say, okay, is this my experience? What's your experience like? But then to sort of say, can we take this, to a broader sort of audience? I think I would love to see more folks engaged with what we do as academics. And I think if we're public facing, if we have these kinds of seminars and webinars, if we have these kinds of exhibitions that are made accessible to all, that's a great way to get this going so that it's sustained, right? This is sort of a sustained way of showing the public what we do, what humanities can do, in a way that allows them to have buy-in and to either say, oh, I've learned something about this, or even in the sense of getting folks, community folks involved, saying we could put on our own exhibition, we could do our own thing. So yeah, I would love to see more of that kind of work out there. And yeah, I would say keep doing what you're doing with these webinars.
You mentioned students and these kinds of student public-facing projects, and I'm wondering whether the pandemic has shaped your university teaching, or if you have other suggestions besides this kind of exhibition work about how teachers can draw from history to support students as they try to make sense of the crisis and the moment that we're in right now. Yeah, so I have to say, so my experience with teaching during the pandemic, it was a whirlwind last spring. So the first thing that shaped my teaching was it was all about the compassion. I was sort of like, okay, and I say this as a person who teaches histories of diseases, and I'm always distant from it. And I'm always like, oh yeah, that happened a long time ago. We don't have to worry about that. And so
then in the spring, last spring, I was sort of like, okay, compassion. Everybody, it's okay to be completely uncertain. I distinctly remember moments where I would say, you know, what did people do? They would flee. And now I'm like, oh man, that's easier said than done. Okay, wow. So one, humanizing this, being very honest with students and saying, look, I honestly, you know, I was like, okay, turn in assignments, right? You still have to do work, but also try and reflect on this moment, because this is like, when you're in the retirement home, you're gonna tell somebody about this. This is like a very important moment in your life, even that right now it might be like, oh, this is terrible, everything. You're gonna reflect on this, and it's gonna tell you a lot about who we are as a society, and you had like a front row seat to it. So I would say, for me, it has been about telling students to reflect on things, to don't sweat the small, like, wow, you've turned in an essay late. I'm like, there is a pandemic on. It's going to be okay. So one, for me, that's what I mean when I say I'm compassion. I would also say that I'm thinking, like, in terms of assignments, that what I'm seeing a lot of my friends and colleagues doing has been to say, we want you to write about what's happening to you if you feel comfortable, right, in doing that. And so, you know, some people say creatively, you know, post a video, right? Something that's easy to do rather than having you sit through just like a lecture and take notes, which maybe people aren't doing, but something to say like, I'm sharing this and I've created it, and it gets to be yours even after the duration of the class. Do you know what I mean? So that's something, a way of sort of giving students something to do, to recognize this moment, to reflect on this moment, that also isn't like busy work. Because honestly, you know, I was teaching African American history last spring, and I'm like, okay, we're totally going to get through Reconstruction. We have to do this. This is super important. I think as political events can tell us, we kind of need to know this history. But also, it's kind of okay if you are overwhelmed right now, and you know, you haven't, like, you know, finished all of your key terms for like the exam. I'm like, it's okay. So yeah, that's, I guess, what I would say from my personal direct experience.
Yeah, so it's interesting, this idea that maybe they are creating some kind of a record that will become a history for others to view.
They are part of the history. I mean, that's the thing, right? That's what I mean when I say you're going to get to tell some wonderful student volunteer when you're, you know, 80. Right. Can I tell you what happened in the spring of 2020?
And then, well, maybe I'll ask the last question, which is that, you know, Arundhati Roy has described the pandemic as a portal, a gateway between one world and the next. To what extent do you think this is true? I mean, I think especially as a historian, do you think this is true? What do those of us living in the US carry through this portal, and what should we leave behind?
Yeah, so this is a new, so I have to say, I don't think we're going to be in a place where everything's back to normal, right? This has left a big scar. Like, we're going to try, and people are trying now, right, to make things normal, but I don't think that's really going to be the case, right? I think we've stepped through that. We've moved past whatever we thought normal was, and now we're in a completely different sort of, I think, liminal space, actually, right? I like to think of the liminal space as being like when you see a meme of somebody in front of their laptop looking very professional, but then you clearly see like baby toys everywhere. Like that's where I think we are, where it's sort of like, we're trying to carry on, and we're going to say we're soldiering through it, but we're also realizing that we are human and that we're vulnerable, and that it's not, everything is not as it seems. And I think this is a moment where I don't think we can just go back to saying, oh yeah, remember that one time when there was a pandemic and 200,000 people died. I don't see it as something we just move on from. I do think, though, that we're going to move into a different sort of view of what life is supposed to be like, what relationships are like, what social gatherings mean. Like, I'm dying to read the dissertations by anthropology students like 10 years after, to see what bars are like, to see like how people greet each other, the regard people have for each other. What does that mean? Like, bars as a site of resistance now, and people who demand to go into enclosed spaces. Like, there's so much that can be done. And I know it's kind of saying it like kind of jokingly, but I do think we've been changed forever. At the same time, though, we've done this before, right? We've had pandemics before. We've had these epidemics before. And we see some similarities, right? We see some parallels. but I don't think it's ever exactly the same, right? There were leagues of anti-maskers back in like sort of during the Spanish influenza outbreak, but it wasn't quite the same, right? So I think we're just never going to be the same. And I actually don't know, I don't know what we are going to be. Let me put it that way.
Thank you. Thank you. I think we'll open it up to questions. Dr. Fox will help us.
Yes, hi. So we have some questions coming in, but I thought I might start actually, if I may, with a question of my own. That I just was really struck by what the parallel that you were drawing between essential workers now and the demand for essential workers in another time. And I thought it would be, I guess I'd like to hear more about that parallel and maybe link it to how do we get those perspectives is, I guess, because I keep thinking about yes, right? So the emphasis, I think the point you're making that we need to emphasize differences of perspective rather than necessarily bodily difference always, right? I think this is key and so important. How do we capture some of that difference? And so anyway, I'll leave that to you.
Okay, so first of all, thank you so much for your question. And yes, it's like sort of the thing where I went back to chapter 1 and I was like, oh man, this is crazy. Like thinking about the African American community in Philadelphia, they were actually expected to do this, right? The idea of saying, well, you'll be treated much better if you can prove what good citizens you are by staying behind and risking your life and doing the dirty work. And for Benjamin Rush to say, oh, look, this is built in, right? This is your calling. It's determined that you must do this, right? It's almost like, okay, do we really have a choice? And then the idea of saying that we're going to earn respect, right? We have to stay behind during an epidemic, look after the sick, do all of these things. And then I thought to myself, yeah, being caught in a rock and a hard place for people who are kind of forced into the position of saying, well, I really don't want to have to go to work, whether it be at the grocery store where there could be maskless people breathing on me, or working in public transport, or working in places where I don't really want to be, but do I have a choice, right? I need to work, I need to survive, I need to do my part, right? When people say things have to keep going, we have to. But here we are, seeing that sort of you don't really have that choice, and to see that who makes up this population, right? Who are essential workers, right? What was really frustrating to me was that I kept hearing the term like essential workers, but these are often individuals that I think are invisible. Like I never heard anybody, really that concerned about people who are packing groceries, or people who drive, public buses, people who do this kind of work. I'm sort of like, oh, so now they are super visible as the essential workers. But before, they were not, right? There are cases of people going into, let's say like a coffee shop, not wearing a mask, and the person behind the counter is wearing a mask, and there's no one there. And the person behind the counter says, could you please wear a mask? And they say, oh, well, there's nobody here. And it's like, well, I'm here, I'm the worker. I'm the person who has to come in and do this labor that, I have no choice, right? This is my job. So the parallels are there. It was very disconcerting for me to see that. But I think also, I hope, right, that when people are talking about disparities with COVID, there has been this push to name like African Americans, Latinx workers, other people are the folks that are being sort of unfairly thrust and made vulnerable here, and to think about their experiences. I almost want to say that, people who are complaining about wearing masks, or like the difficulties in oh, I have to work from home, that's one perspective. But the other perspective that I would hope to see more of, and I think in people protesting, or in people sort of having these lockdowns, or people having these discussions, is to say, who are the people that don't get to lock down? What is happening to them? What is their story? We should care about this. So yeah, it was weird. It was just a weird moment. I remember like I went back to chapter 1 and I'm like, this is kind of like what happened to the Free African Society in Philadelphia. And it makes me very unhappy.
Yeah, I mean, and recognizing the ways in which, right, income inequality has created a situation of precarity where people are suffering in different ways, right? I mean, I think also coming out of your talk, I think that that's a really valuable way of thinking about it in terms of different kinds of suffering too. So thank you. I was hugely struck by that parallel. Okay, so let me offer up some of these questions that are coming in the Q&A. One of my lovely colleagues says she doesn't teach primarily students at ASU who are history majors, but she really appreciated your focus on the need for students to create content and public-facing history, and that a significant role for historians is to realize that it's people outside the academy who need more history. Can you give more examples from your work or career that might give people ideas about how to do that? She says she has concerns that priorities remain too much associated with a more insular traditional approach about what matters in the field and is, right, focused inward. She also said that Journal of the Plague Year rocks. That was her final comment. So.
Okay, so I'm glad that I'm glad I'm in good company here, because like I love assignments. I love reading it every time. Okay, so to the question though, which is a great question in terms of like thinking about creating content and public facing, which I absolutely agree that there needs to be more consumption of this sort of for folks outside of the academy. So in my experience, I have to say, you know, what I've been asked to help with like curating things for museums, right? So they'll say, okay, should we put this object here? What does it mean? And I'm happy to do that. What I am a big fan of, and I can't claim this as my own idea, but what I have found is that universities have archives, right? They have, you know, their history, their telling of their story. And to create projects where you could have folks come up with sort of looking for things in the archives and then having folks digitize those things to tell the institutional history of where they're going to school. Why this matters, I went to Ole Miss. I have to give the shout out to Ole Miss. And I believe it was Ann Twitty, she's a historian there, and she had undergraduate students who were going into the archives talking about the very uncomfortable history and legacy of slavery on the campus, and having students like take ownership over saying, okay, when giving tours or knowing what this monument is or knowing who this hall is named after, which I was sort of like, yes, have students say, okay, I'm going away to school and this is, but your school has a history. And you might be say, okay, I know this building, that's where I have, you know, my English class. Well, who's it named after? And having students do the digging themselves and then having them sort of be able to create that content so that you could have a website or anything like that makes, I think is a great idea to, one, get students involved in it and invested, and to kind of, you know, be an eye-opening experience, but also I think for parents, for other people that go through these institutions to know what that is helpful. I think this could be applied in a variety of settings. And I feel like I've talked to other historians who do this, right? Who, if they have a rich archive, if they have access to either sites that are close to their institution where they will take students there and have them get their hands dirty. And I think that for folks, you know, who are maybe not at college or, you know, are not close to these kinds of institutions, I'm a big fan of like exhibitions. I'm a big fan of sort of public talks or things that are accessible to people who might naturally just be curious and interested, but maybe they don't want to go through and read like, you know, 10 books from an academic press, which I can completely understand if you're not in a graduate seminar, sure. So I think that like if there are ways to encourage the public to sort of tie events that are maybe local to a community, but then also have a historical component to it as well, make a lot of sense. This is why I was super impressed with what, as I said, what Deirdre Cooper Owens had done at the library company, because it's not only is it students getting involved, it's sort of making a public facing thing now that anybody can consume. And it's telling a history that I think a lot of people don't know about with respect to race and epidemics and health. So this is, for me, I would love to see more of that. And I recently did something at UNC where they had like sort of an exhibition on like race and racial differences. And I was happy to, you know, help out in the way that a historian can say, okay, you should put this in context, or the idea though that it's open to everybody to come and see and look at these artifacts, right? To not just read text, but think about objects. So yeah, those are ways in which I think we can be more public facing.
Those are fantastic suggestions and examples. Okay, so we have another question that is a bigger question. She wants to know, how can we go about creating or perpetuating a change in how Black patients are treated in medicine? And once this begins to occur, how can we measure it, right? So this is someone who is, I think, trying to open up this larger question of, okay, so there's this history of not accounting for suffering. What do we do?
Yes, no, and I'm actually really glad whenever I get that question. I'm like, yes, so I love when either clinicians, nurses, whoever come up to me and say, okay, look, we got it. So now what do we do? So one of the things, and again, I can't imagine what it's like to be a very busy physician or nurse and stuff like that. But one thing I would say is listening to patients. And when I say listening, not just like, okay, they're talking to you, but like listening and then looking at sort of how they maybe feel or reading the room when they're there, right? So one thing that I've noticed is people being dismissed, right? A big concern is that, particularly when we think about African-American women's maternal mortality, which is just unacceptably high. The complaints that you might hear is that my pain was dismissed. Nobody believed me. Nobody listened to me. There was an assumption that was made that I was either making it up or that I would be just fine, right? And so I think that's a moment, that's a critical moment where for the practitioner, I'm sure they have to say, look, I need to manage how do I manage, right? Okay, this is a case where yes, this is unusual pain or that this is normal. That's tricky. I'm not saying that it's an easy thing for a clinician to do, but to also make sure that when they're talking to the patient that they're seeing them and saying, okay, I want to actually discuss with you what the pain is rather than saying, okay, you're going to be fine, right? So and making it comfortable, I guess, for the patient to want to do that, because I think there's so much sort of unspoken baggage that can occur in the doctor-patient relationship, especially when you think about, for example, physicians that might teach that might work at teaching hospitals, where they may go home to the suburbs far away and their teaching hospital is in a place that has a completely different racial demographic. And there's like this huge distance where they're like, I go away from there and I go there to, either teach medical students and this is my job. And there's like this disconnect, right? That's a problem. I think that problem can spill out in your doctor-patient relationship. I think that can spill out in terms of how much the community feels that you care about them rather than saying, okay, students are there just to learn from them. And I say this as, having spent time in Baltimore, seeing that the emergency room at Johns Hopkins is a busy place and, med students saying, oh, it's great, you can see all these gunshot wounds. And I'm sort of like, whoa, that's a person. That's an actual person. Sure, you need practice and that's important, but recognizing one, that these are people who maybe are thrust into a situation where there's a lot of gun violence and that's a larger systemic problem. So I guess it's kind of saying, being able to look at each patient individually, but then also recognize the environment for that patient, the context that they have to navigate, and think about, listen to them before you say something like, oh, well, it's just another one of these, or, oh, well, it's not that important, or, oh, well, you'll be fine. I do think a lot of these cases are sort of unconscious. Like, I don't think that there are physicians that are naturally going out there being like, oh, I'm going to ignore every minority patient I have. But I think there is sort of this unconscious bias that's been built into expectations in medical training that somehow needs to be broken. I wish I had a solution for how to fix medical training and all of that, but I unfortunately do not.
All right. Well, thank you for that terrific answer. Annika, I wanted to see if you had any other questions of your own maybe coming out of that.
Yeah, I mean, I have so many, but I was struck by what I think of as a classical move that historians could make, where you tell us this point of view was not aberrant, but representative, right? Mm-hmm. This view about difference, it's not aberrant, but representative. And I'm wondering whether you think that still obtains this view of racial difference. Is it still actually representative and not aberrant? And what we can do to convince current publics about, because I think it's easy to dismiss if it's aberrant.
Right.
But it's much harder. You're in for greater work if you say this is representative. So how is it still such, and what do we do about it, about convincing people of that?
So yeah, here's what I will say. I think that I do not think it's aberrant. I think that for me, the issue I see is how people frame research questions and how people frame statements and messaging about racial disparities. So for example, people say, oh, there's no biological basis for race. It's not a thing. Oh no, it's a social construct. And I'll say, that's really great. But what do we do about the FDA that's approved Bidal, which is the only FDA approved drugs for people who self-identify as African-American? I'm like, so are you saying that we get congestive heart failure differently? Is that really what you're saying? Or are you saying, well, we're not sure, but we're going to go ahead and say that anyway? So if you do that, it makes it seem that you're then saying, what is it about Black people that makes them? And I'm like, that's your problem. The same way when people say, oh, why is it that African-American people have so much hypertension? It's like, whoa, whoa, whoa. Okay. So you can notice a trend, right, in a group of people, and you can ask questions in a variety of ways. But if we keep asking the question where we put the burden on you explain yourself why you are different, rather than saying, what are the factors that might lead to these higher? That way, I say this because there are times where I've given talks where people have shuffled up to me and said, but there are racial differences. Black people get sickle cell anemia. And I'm like, yeah, so do people from the Mediterranean, and so do people from other parts of the world. It's actually a molecular disorder. Like, but you know, then I say that and their eyes kind of glaze over because they've already made their point that of course people are different. So for me, it's about framing and messaging. And until we change the framing and messaging, it really does look like we have something built into the system of how we frame research and message, that we're putting an emphasis on race in a way that's not great. So I did see some signs of hope where, looking at the CDC website, where they will say, sometimes I just like check in on the CDC website. I will completely admit this, that I just kind of troll, like I lurk on their website. And so it does say, for example, in talking about racial disparities, they've listed things like discrimination, lack of access to care, like all of these factors, which I'm like, that's great. I am super glad to see that you are considering racism, discrimination, lack of access to care, lack of, underinsurance, all of these things. I'm like, yes, that is a great way to have our conversation then about why racial disparities exist and persist. That is not the comparison, kind of stark comparison and contrast. So that's more for messaging, I would say. But I do think it's kind of built into the system because I didn't mention this in the talk because it's just like there's so much this short time. But when I say that Benjamin Russ was asking the question of why is black skin black, there was actually a competition in France in like the middle of the 18th century for somebody to come up with the best explanation for why black skin is black. Like people entered like essays and saying, I figured it out. So that means it's like, when can Black people stop being a research question, I guess, is sort of where I'm going with this. And when that stops, I think that we're in a better place, or we're moving into a better direction. Thank you.
All right. On that note of maybe moving into that better direction, I want to thank you so much for joining us today. Thank you, Annika, for helping to host. It has been such a pleasure. And thank you all for joining us who out there in the webinar universe. And we hope that these conversations will continue and that we will continue to find ways of encouraging this kind of research. So thank you very much, Professor Hogarth.
Thank you. Thank you very much for having me.